There are millions of people, in fact, close to 40 million, that have a diagnosis of migraines in the US alone. Very difficult to treat. A significant number of those patients actually don't have a chemical problem that's able to be treated with medicine. They actually have a mechanical problem. There's something physically pressing on and or irritating a nerve. You can decompress those nerves. And while sometimes, as you correctly pointed out, nerves are permanently injured and there's nothing you can do to repair the nerve, you can actually bury the nerve after removing the injured part and basically make it go to sleep. So at least the pain is gone. But thankfully, in many cases, you can actually decompress the nerve, and with time, take the pressure off the nerve will function more normally again. The really exciting part is now we have the ability to use some regenerative medicine techniques to help push that process along, which has improved our results even more.
Hello there. In this episode, I have Dr. Ziv Peled. He is a fellowship trained, board certified, Harvard trained plastic surgeon and peripheral nerve specialist who practices in San Francisco, California, my hometown. And I am very excited to have him on this episode because he is the person to talk about if you are interested in peripheral nerve procedures, headache surgery, as in headache relief, but in a very different way, and sensation preserving procedures as well too. So welcome, Dr. Peled.
Thank you, Anne. It's a pleasure to be here with you. Really appreciate the opportunity.
Thank you for being here. So let's dive into this. So you're a plastic surgeon, but your focus is a little bit different. What made you kind of focus to plastic surgery to nerve preservation and restoration?
When I was finishing my training, I was actually in my 9th year of residency between research and all the prereqs, et cetera. And I happened to run into a colleague of mine who had done a peripheral nerve fellowship. And I got the opportunity to follow him for a couple of days. I was actually at another meeting, but the meeting wasn't very interesting. So he said, "Hey, come see what I do in my office." And I did. And I was watching patient after patient after patient wake up, feeling things they hadn't felt before, not feeling the pain that they had before, moving things that they hadn't moved in years and months. And I was so blown away that I actually called my parents at, some absurd hour in the morning. And I said, "You won't believe what I just experienced in the office. I'm going to skip the meeting tomorrow. My bosses are going to be really upset, but I'm going to go watch him again," because I couldn't believe it was real. And sure enough, I did the same thing the next day. And it was the same in the clinic and in the, recovery room. And so I ended up doing a 10th year of postgraduate training, just focused on peripheral nerve surgery. And, it was the best decision I ever made because it's really been a wonderful niche, especially starting in San Francisco, where it was a very busy and full market already for plastic surgeons of your standard type, so to speak. And it's actually been a wonderful experience, really just making patients' lives better, as you know, because you trained in pain. And when that pain is better or goes away, you really feel like you've changed people's lives, and they will tell you that.
Coming from a pain perspective, being trained, I finished fellowship in late 90s, in fact, 1997. We were kind of like, well, if the nerve's been cut, the nerve's been damaged, you gotta live with it, like foot drop or, trauma, nerve injury. That's it. There's, nothing much we can do except for gabapentin and opioids and, and maybe a nerve block. But that was more like a maybe. So what you're doing is very, very interesting in that. Tell us more about what you're doing with the headache surgery approach, because that has always been a challenge from a pain management perspective, managing headache.
There are millions of people, in fact, close to 40 million, that have a diagnosis of migraines in the US alone, much less worldwide. It's actually this disease with the second most years lived with disability, according to major international and multinational studies. Anyway, very difficult to treat. But a significant number of those patients actually don't have a chemical problem that's able to be treated with medicine. They actually have a mechanical problem. There's something physically pressing on and or irritating a nerve. It's an abnormal blood vessel, an enlarged lymph node, like we've seen a lot since COVID, spastic muscle, scar tissue from prior surgery or injuries, even just kind of bonking your head on a cabinet door that was open when you stood up, or a soccer header, which we see a lot of.
Mm.
And so you can decompress those nerves. And while sometimes, as you correctly pointed out, nerves are permanently injured and there's nothing you can do to repair the nerve, you can actually bury the nerve after removing the injured part and basically make it go to sleep. So at least the pain is gone. But thankfully, in many cases, you can actually decompress the nerve, and with time, take the pressure off the nerve, the nerve will function more normally again. And the really exciting part is now we have the ability to use some regenerative medicine techniques to help push that process along, which has improved our results even more.
So, how have you combined the regenerative medicine with the nerve procedures?
Typically, the first step would be to do a decompression. So you do an operation to take the pressure off the nerve. Think of carpal tunnel surgery and carpal tunnel syndrome. That's a nerve compression problem, and the carpal tunnel release is a decompression procedure. And in many cases, those work really well and patients do very well. But there is a small subset of people, because nothing works perfectly, that still have some degree of pain. And the presumption in those cases, assuming the surgery was done correctly, which it is in the vast majority of clinicians' cases, there has been some permanent damage to the nerve. But what we're realizing is that permanent damage may actually not be permanent. And so you can actually put some microfat and nanofat around these nerves that have been decompressed. And what I'm finding in a study that I hope to publish by the end of the year, specifically with regard to the recalcitrant headache surgery patients who still have some degree of pain, is that their pain improves so much that we no longer presume the nerve is permanently injured like we thought and have to cut that nerve, leaving them with numbness. And it's a combination of microfat and nanofat. And it's a very, very exciting thing, because it mirrors what we've seen in the breast surgery space with fat grafting, where we see improvement in the radiation damage that people have in the skin of the breast when you fat graft underneath it. And it seems that we're actually helping the nerves regenerate and function more normally, and hence decreasing pain in these cases too.
Have you seen cases where using regenerative medicine, particularly with nano or microfat, and nerve that's been transected and then reconnecting again? Have you seen that nerve come back?
We haven't seen that in and of itself, that it would come back spontaneously. However, one area that's really of interest is whenever you do a nerve repair. So let's say a nerve has been cut in two, and you can find a nerve graft to bridge the gap or actually do a primary repair. Again, the results in the literature are always somewhat mixed, and there's a number of reasons for that. But what a lot of people are working on is how can we enhance that nerve regrowth and that nerve repair. And there is a lot of very exciting basic science research in animal models now, but I'm sure soon to be in human models, that putting fat around these nerves can actually improve the outcomes from a sensory and motor standpoint in nerves that you repair. So yes, you can. I think probably within the next 10 years, we'll see in the office ways to take someone whose nerve was cut in two even years prior, be able to try and reconstruct that nerve with a graft of some sort, and then put fat around that nerve to help enhance the regrowth of those neurons through the graft to yield a return of sensation, or perhaps, depending on the timing, of course, some motor function.
Wow, that sounds very, very exciting, especially come from my approach there. So, how? What are the number one procedures that you do in your practice?
For me, it's a combination of three things. Number one, I do what we call sensation preserving mastectomy or top surgery. So traditionally, when you have a mastectomy, people are completely numb from armpit to armpit over a huge swath of their chest, because all the sensory nerves that provide that sensation are removed en bloc, meaning in one piece with the breast tissue. So we can now either preserve those nerves or reconstruct those nerves so that within 6 to 12 months post-op, most people have pretty darn good sensation in that chest wall skin and in the nipple-areolar complex, even with flaps or implants in place. And that is done obviously in both the cisgender and the transgender patient population. And then a lot of headache surgery, as we've already spoken about. And we do a fair bit of lower extremity and truncal nerve work,
Hmm.
as well as now a bit of nanofat with microneedling for some of the persistent allodynia, meaning the painful
Mm.
skin conditions from those little nerve endings that have been injured for so long. And so, like many things, a multimodality approach seems to be really the ticket to the optimal result.
What do you mean by multimodality approach?
So you might have surgery, you might have some medication, you might have certain lifestyle modifications or PT that you use for some period of time. But then on top of that, we're adding regenerative approaches here. If you have some persistent hyperesthesia where you had a nerve that was injured for many, many years, you do an operation, for example, 60, 70% of the pain gets better, but it's still bothersome enough. And yet you'd rather not be numb. You'd rather not have another operation. You can do an in-office procedure that with like microneedling and nanofat that will help with that hyperesthesia even more.
That's awesome. And can you do that in any allodynia or hyperesthesia in at all extremities?
Theoretically, you should be able to. We're starting our patient population to try and keep the data as clean as possible in the headache
Mm.
population at first. But once that data is out, I have done it for the lower extremity and the trunk, and it seems to work just as well, which makes sense because nerves are nerves that just happen to be in a different location.
Right, and you mentioned something fascinating that is phantom pain from,
Mhm.
or even residual limb pain from
Mhm.
amputation.
Yeah.
Now,
Yeah.
that I mean, we see that a lot in the pain
Mhm.
management
Yeah.
arena, and by doing that in itself will change so many lives. But that is more common than we think it is, especially from trauma-induced um, amputation.
Yeah. Yeah. It's a very exciting avenue because I think that what we're really talking about is making the nerves themselves function better. We're able to structurally and physically do things to the nerves. You can repair them just like you can repair laceration in the skin or a broken bone. Uh, but we will never be able to recapitulate with sutures, no matter how fine, what the body can do healing on its own. And so the idea that we can really help it do what it needs to do is really exciting.
The question I want to highlight is what, and with the summit coming up on July
Mhm.
30th to August 2nd, what will you be teaching at the summit?
I'll be talking about my work with nerve pain patients, specifically headache and sensation preserving mastectomy, but also some lower extremity nerve issues. Um, and we'll be moderating a couple sessions there as well. And we help with the ultrasound sessions to show you how I like to highlight nerves,
Mm.
and then working in the cadaver lab to show people how I do my perineural injections, and then we can do some cut downs to see how close we've come to injecting in the right place, so we can learn um,
Mhm.
in human tissue how all of this is supposed to work.
So you're going to be showing ultrasound guidance, perineural injection with nanofat.
We will be showing the ultrasound topography of some of these common nerves that we treat.
Mm.
And in the cadaver lab, we'll get a chance to practice some of that on various parts of the body so that you can inject and see. You never want to do an intraneural injection. You want to put this fat around the nerve. So you can get to practice with an ultrasound probe, the right depth level to put it in. And then you can actually cut down on the cadaver itself and see, hey, I was too superficial. I was inside the nerve. I was, right where I wanted to be, and get a real feel for what that could feel like in a human being.
Having said that, what I wanted to ask you is that what make the summit so different. The conference that will be on July 30th to August 2nd in Torrey Pine, so different than other regenerative medicine conferences.
What I like about this is really a combination of factors. First of all, the meeting is pretty small and intimate, so uh, obviously space is limited, but that also is a wonderful thing because you really get to meet a lot of the participants as well as a lot of the speakers. I think that affords you the opportunity because there's also a lot of post didactic events to really kind of sit down and just chat and say, hey, you do this. Or I had a patient that had this problem, like how would you approach this? And I think a lot of the kind of little pearls that you pick up from what people are doing and where you can really learn from them happens in that kind of one-on-one setting. And I think the cadaver lab is a real important value add because I think that it's a great jumping off point to saying, okay, here are the theoretical things. I heard someone say this. I saw a picture or two or a video or two of what they're doing, but can I really do this? And you get a flavor for what that could be like. And in terms of like the actual practical, okay, so if I'm going to do this in my office when I go back to work on Monday, what is it I'm actually going to be doing and how should I set it up? And I think that gives you a good jumping off point. So it's just a great meeting for so many reasons.
Absolutely. And what I find great is that you get a chance to really talk to the speakers who are the expert in their field and how the speakers are so open to talking with participant as well. So if a doctor is at the summit, what question would you would like him or her to come and ask you?
There's a mentor of mine that was very fond of saying, Ziv, you have to be able to see what you're looking at. So there's so many people who have pain and everybody goes, well, that's just kind of how it is. It must be something you're just going to have to live with. And I think that anyone that has pain shouldn't have to accept that they have to live with that forever. That's not to say that there's some magic bullet, but there's always a way to try and manage that pain in a better way. Anybody that has any pain for whatever reason, I'm happy to speak with. We've even seen patients in the past who are on palliative courses because of a malignancy somewhere. But wouldn't you know it, the tumor happens to be on a nerve. And yes, it's not resectable for a cure at that point, but you can do things to the nerve itself so that at least the pain in those few remaining days, weeks, months is minimized, which means that person can really be present and not completely under the influence of a lot of opiates and pain medications to try and dull that discomfort. And you really get a chance to be present with your friends and family in those final moments. And so I think the idea that pain management is sometimes impossible, I think there's a lot more we haven't fully realized yet. So it's very exciting.
Absolutely. So, pain is one of the most complex condition to treat, but yet very fascinating. And as you were talking, I wanted to dive into there are several specialists that treat nerve pain and nerve surgeon, vascular surgeon and also plastic surgeon and general surgeon as well. How is your perspective from a plastic surgery trained and then nerve peripheral nerve specialist? How does that unique perspective different?
The term plastic comes from the Greek word plastikos, which means to change shape or to mold. And I think that you can really take that same approach to nerves. So you don't necessarily want to change the shape of a nerve, but if there's a divot because of pressure on a nerve, you can remove that. And so as plastic surgeons, we're basically trained to try and enhance and improve function and appearance. That's really what plastic surgery is at its heart. And I think it can be done with nerves as well. So I think it's a combination of that mindset and a good skill set to be able to work with very fine objects and fine instrumentation to optimize the results while minimizing the trauma which is already present to the nerves additionally in many cases.
It sounds like a very comprehensive approach in treating the root cause of
Exactly.
the nerve rather than just a symptom management, which is what
Correct.
I was trained to do in the late 90s, because that was, medicine then. At that time, we only had the tools that we have at that time, and
Right.
medicine is evolving, right?
Always. Yep. Very,
Yeah.
and it's in the most wonderful ways.
One more question. How do you feel about doc that are interested in learning regenerative medicine? Is it optional or is it a must?
I would say you're going to be behind the eight ball in a big way if you don't at least pay attention to and start thinking about how to incorporate elements of regenerative medicine into your practice. It is a very exciting, seemingly very powerful field. And I think, much like AI, there are people that say, I'm not going to do this, let the robots take over if they can. I'm just going to be me. And there will always be, I think, room for human beings. And we're not going to eliminate medicine. We're not going to eliminate surgery. But I think, much like the concept of AI itself, we can use regenerative medicine to enhance what we're already doing. And I think if you don't start thinking and learning about these things, you will be a little bit far behind.
In fact, when I learned how to do fat, I was trained by a plastic surgeon, which is Dr. Bob Alexander, and at least like 17 years ago. So that's how I was fascinated with the plastic surgery field and how you guys extract fat, because the technique I've learned was from him in a minimally invasive.
Good person to learn from. Yeah.
Yes, he was the only person to learn from if you're interested in
Yeah.
doing fat around 2007 at that time. So it was exciting. Having said that, doctors, if you are interested in learning about pain, it's actually pain from perspective of a plastic surgeon who does nerve preservation and restoration. And if you're interested in learning about regenerative medicine, think about coming to the summit in Torrey Pine on July 30th to August 2nd, and come and talk to Dr. Peled and ask him questions about what he does and how is it going to be applicable to what you're doing in your practice, and how you can incorporate a nano fat or even micro fat, and learning the procedure into your practice. If you're new, come to the lab on Sunday, August the 2nd, and see the expert do their magic and perform their magic on cadavers. And that's how I learned in regenerative medicine. It's on cadavers and just watching the expert do it and ask questions and practice. Make sure you talk with Dr. Peled. And Dr. Peled, thank you for being on this episode. And we look forward to seeing you at the summit.
Thank you very much, Ann. It's been a pleasure.
All right. Thank you.